afternoon, everyone, and welcome to today's session of Black Health Trust. We are so happy that you chose to spend some time with us. As usual, there's a lot to talk about, and we can't wait to jump right into it. We're going to have a special guest today, Dr. Oliver Brooks, who is a member of ACIP, and we can pick his brain as to what's going on with that. And we have the second part of a series started by Dr. V on the neuropsychology of children with behavior issues. So without further ado, I will turn it over to our founder, Dr. Randall Maxey.
Thank you very much, Dr. Barbara Neighbor-Stevens. Thank you to my co-hosts and our advisory board as well. We hope to have a lively discussion. As Dr. Neighbor-Stevens said, I met her when she was Dr. Barbara Neighbor. I keep forgetting to add the Neighbor-Stevens part, but I don't mean that in any disrespect, Dr. Neighbor-Stevens. I'm just getting old. Okay. So for the first few minutes, I want to have a timely issue. One of our advisory members, who is the recent past president of the National Medical Association, who is the chief medical officer of the Watts Health Plan, and who is a distinguished member of the ACIP, which is the advisory committee to the CDC, who was quoted on our show last week as having cast his vote, and he qualified why he cast it as did. And I'd like to have a chance for us to put a few questions to him. Then our invited so-called keynote speaker today is Dr. Yehudi Y. I call him Dr. V, so I don't mess up his last name, who is an adjunct professor at a university in Florida. We'll introduce him at that time. So Barbara, you got to tell me how to spell ado. Without further ado, I'd like to show the first of the several slides I want to discuss with Dr. Brooks.
Dr. Maxey, that's why we talk, so we don't have to spell things. It's okay.
I usually have a habit. I try not to say things I can't spell too often, but that's a lot. So is this the first slide, Simon? Okay. There's a recent study that showed that COVID-19 vaccine prevented approximately 27 million infections in US adults. And according to that same recent study, the percentage of infections, of hospitalizations and deaths that were prevented from COVID-19 increased with greater vaccine coverage, according to that study. Next slide. A lot of us have been concerned about long COVID. And there was a new study from researchers at Boston. There's a little bitty school up there called Harvard Medical, and they found that the spike protein of the SARS-CoV-2 virus may linger in long COVID patients' blood for up to a year after the infection. The findings reinforce the leading theory that among scientists that the lingering virus particles stimulate an immune system reaction that causes those symptoms of what they call post-acute syndrome. And the last slide. So who should get the updated coronavirus vaccine booster now, and who should wait? The CDC has this month greenlit the rollout of updated COVID-19 vaccine boosters. These shots will replace the boosters previously offered in the US, such that for people 12 and older, being up to date with vaccines mean having the new shot. Dr. Oliver Brooks, love to have your comment on these items and so appreciate you very much and getting on the program with us to give us an update on the vaccine and these lingering questions.
Right. Well, certainly. So first of all, I want to acknowledge I'm honored to be on with you, Dr. Maxey. I would also like to acknowledge my colleague, Dr. Barbara Britt Stevens, Dr. Wilbur Jordan, nationally known expert, and a local individual in terms of the work he's done in Los Angeles, HIV/AIDS trailblazer. And then my buddy, Dr. Jesse Sherrod, I haven't seen in a while, but it's really good to see Jesse to an icon in the pediatric community, honored by the section pediatrics for a lifetime of her work. So in terms of looking at those three slides, first of all, yeah, vaccine prevented 27 million infections in adults. The data also shows worldwide it prevented between 13 and 16 million deaths. 13 to 16 million deaths. And the second aspect of the statement, the vaccine, the more people get vaccinated, the more protection there is because your immunity is stronger. It's covering what new variants may be around. So it is crucial that people get vaccinated. It's about the only thing we can do other than treat, and as physicians, we always want to prevent illness rather than treat it. The second thing, long COVID is actually a primary focus of mine. It is my greatest fear. The death rate is low, even with the BA.4/5 variant, the death rate increased, and the delta between those 65 and older and those lower increased. So for those seniors, there is a significant risk of death from even the present variant BA.4/5. But the majority of those that are getting COVID now are not getting hospitalized. They're not dying. But we have some evidence, but we really don't. This long COVID thing is going to be with us for decades, I imagine. There is some evidence that vaccination reduces the potential for long COVID. That may seem obvious, but the data is not real strong yet. It's intuitive, but I'm really looking for more data. And I really like the fact that this study was provided by you at Black Health Trust. This is where the focus is going to end up being, not on acute COVID, but chronic COVID, or as it's called, long. I believe it means having persistent symptoms 6 weeks after resolution of the acute infection. And then the last thing, which is obviously the most, is the new vaccine, quote unquote, new vaccine, the booster. So we have a bivalent booster that was passed on passed by the FDA, approved by the FDA on September 30th or 29th. And then the recommendation affirmed by the ACIP on September 1st. So it's a bivalent booster, has the ancestral or Wuhan strain linked with the BA.4/5 strain. And one thing I'd like to just add, the BA.4/5 are two different variants, but they have the same spike protein. So that's when you hear us putting them together. They're different viruses, but the antigenic site of the spike protein is the same between the two. And the recommendation now, everyone that is 12 and up should get a booster at least 2 months after your last shot. So it gets a little tricky. The timings are really tricky now, but the fundamental recommendation 2 months after you got your last vaccine. There's some pretty good evidence that if you've had COVID recently in the last 90 days, that it is reasonable to wait 90 days from resolution of symptoms or from your positive test to get the booster. The safety data is strong. The immunogenicity was compared to a regular booster, which was with the Delta strain, I believe is what the booster was. Studies were done with the BA.1 and the Delta. I mean, BA.1, the ancestral strain, but the vaccine approved was the BA.4/5, and that's a little tricky. So I want to be very transparent about that. The vaccine that is presently approved, the data was from mouse studies, immunogenicity studies. The safety data was from the bivalent ancestral BA.1. I had some reservations about that, but in the end, I was one of 13 that voted yes. One person voted no. So it was 13-1 versus 1. Anyone 12 and older should get the Pfizer, 12 to 17, and 18 and up can get either one. And I strongly recommend getting it. The data is clear that the vaccine is safe and effective, and your antibody levels drop off. So I'll stop there, Dr. Maxey, to see what I didn't address and whatever questions may be there in the audience.
Well, and thank you so much. I'd like you to comment on one thing before Dr. Neighbor and Dr. Walks and Dr. Hines jump in. And I think I was the most vaccinated person in the world beside Dr. Richard Allen Williams. I've had my original 2 mRNA vaccines. I had 2 boosters. I think maybe I even had 3. And then I got shot up before I went to the NMA with something called Evu Shield. And I came back and I was negative. But 2 weeks after I came back, I actually got sick. The good thing about it, being a senior citizen, I didn't get very sick, but I had to isolate myself from my family. And it took me 6 days to become negative. And I recently treated a 90-year-old physician colleague of ours who also had been vaccinated, but he wasn't very sick, but we gave him Paxlovid as I took. I'd just like you to comment on the fact that even though I didn't think I would get positive, I weathered it because I was vaccinated, boosted, and I call it shot up.
So first of all, it sounds like you're not double boosted. I do want to understand that, because at this point, the recommendation should be that people got 2 primary series. The primary series was, generally speaking, was 2, and then 2 boosters. So if you've only had 1 booster, you were not fully boosted, excluding what happened in the last week.
No, I had 2.
Okay, good, very good. So then you raise a very good point. I remember this from early on. This is important. When the studies were being provided to us, and there's some background like radio something, just noting someone theoretically should likely mute. The purpose of getting vaccinated was to not get hospitalized, not be in the unit, and not die. So early on, I was always looking for data on transmission and data on asymptomatic infection. And the studies were not structured to look for either of those things from the beginning, from the very first Pfizer Moderna. So
hold on
the
one
bottom
second,
line
Simon.
is,
Can you mute whoever's making that noise if you can find out? Somebody has a television or radio going in the
sounds like
background.
it's muted now. There.
Okay. Go ahead, Doctor.
Yeah, so the key is that it's still there, that noise, by the way, but the key is that you, Dr. Maxey, who was probably like 64 and a half, so you almost made that 65-year cutoff. You didn't get hospitalized. You weren't on oxygen. You weren't in the unit, and you are A&W right now, alive and well. So it worked. The other thing is, I can't remember if it's the BA.4/5 or if there's another variant now, but something is either this one or this one that we're now picking up, I think it's BA.4.6, is now evading Evu Shield. So that's concerning. This gets all the way back to getting vaccinated. I had a question with another group where I spoke. They said, well, I'm not gonna get vaccinated. I'll just get treated if I get it. I said, that's not the approach. So I just want to be very clear that the vaccine, as it relates to you, in fact, worked, because it did what it was designed to do, which was to keep you alive and out the hospital. You're muted now, sir.
So Dr. Neighbor Stevens, Walks, and Hines, if you have some brief questions, I'd like to put to Dr. Brooks, and then we can go to Dr. B.
Well, thank you so much. I was wondering if you have been told when we can receive more information regarding the neutralizing antibody levels, which was one of the points that seemed to be concerning to some individuals regarding this new, the new
Yeah,
bivalent.
okay. So you mean the BA.4/5?
Yes, the bivalent.
Right. But you're right. So clinical studies are ongoing. I don't know when. It's a good question. I don't know. It'll, as soon as they're available, they will be out. But again, one of the key questions someone asked during the ACIP was, is the vaccine manufactured the same platform? So the same way we do with influenza vaccine, we tailor it to what's the circulating virus in the Southern Hemisphere for us. I don't know when. I believe the neutralizing antibody information will come out soon, but also don't forget, this is important. There's T-cell immunity also. So even if you see some neutralizing antibody levels drop off, we feel that T-cell immunity is helpful and maybe a little longer lasting than the neutralizing antibodies. But as soon as it comes out, obviously it'll be circulated.
Thank you. Dr. Walks and Dr. Hines.
So, Dr. Brooks, thank you so much for coming on and being with us this afternoon. I wanted to go back to something because a lot of what we do here on the Black Health Trust is to get information out to the community. And I know that our message has been that the vaccines reduce hospitalization and death, and that's it. I remember at the beginning, and this is where I think we had a challenge we continue to have within many communities. Vaccines were given so you didn't get the disease. We get a polio vaccine so we don't get polio. And so there was this message at the beginning that we have a vaccine and you're not going to get sick, because that was consistent with other vaccines and it made sense to people. And so I think that I don't know that change in message from what we used to say was handled as well as it could be. And I think we're still dealing with some of that. We're trying to help people understand that vaccines are great. And Dr. Maxey was the only person in front of me, because he and I both pushed people out of the way to get our booster and our second booster. But not everyone is on that page yet. And so now we're telling folks to get yet another booster. I like the fact that we're talking about it like the flu vaccine, where every year we maybe have a different flu vaccine. Every year, it's not 100%. People still get the flu, but we still recommend it because it saves a lot of lives and it keeps a lot of people healthy. And so I guess my statement is that I really like the way the messaging is now, and comparing it with the flu vaccine, with the change and with the update. And I guess my question is, how are you thinking we best message to the community now? Look, I understand people around you have gotten their boosters and they're still getting COVID, but go get your booster anyway. How do we best message that?
That's a very good question, because it cuts to the chase. I like tying it in with influenza. However, there's a lot of mistrust in the Black community about influenza. So I can't use that approach. I mean, I can kind of do that. I think that what I start with is it's safe and effective, and it's the best thing we have. And that I also talk about long COVID all the time. That's why I think that slide was so crucial. As far as I know, there's no long influenza syndrome. So I really focus on that. I also focus on the fact that you still can die, and so even though you're still may get COVID, and everyone in their cousin, from everyone in my family within the last month had COVID.
Mm.
And we wear a mask even now. We're on a plane and all. So I say that you can still die from it. You don't want long COVID, and there's no downside. That's what I keep telling people. It's safe, and it's safe. You go get your shot. You spend an extra 15 minutes, your arm's sore for 2 days, but you did something to help protect yourself.
Amen.
Dr. Hines, and let me say before Dr. Hines speaks, I had the most favorable, fun, inspiring meeting with Dr. Hines a couple of weeks ago. She came to California, and I tried my best to steal her and not let her go back to Maryland, Dr. Walks. Dr. Hines?
Just one hopefully shorter question, and then I'm going to defer because we've got several questions in the chat. But one of the things that has been definitely bubbling recently is, should I get this, for some people, their third booster, right? Second or third booster now, or should I wait till further into the fall season? Because if we look at the last couple of years, the likelihood is, we're going to go into the later fall, winter months, and things are going to ramp up again. So any thoughts on what to do with that messaging, in the sense of, should you wait, right? Knowing that, if you get it in September, you might be in January having the same conversation again, or wait till later in the fall, or go for it now, or.
Yeah, that's a really good question. I don't have a good answer for that. I would kind of think it would be based on when you had your last booster, because the minimum time is 2 months. But if you got your booster 2 months ago, I would wait a little while, because your immunity drops off. It looks like it drops off like about 3 to 6 months. So you're pretty well protected. That is a real, there's no clear answer to that. I personally would recommend getting vaccinated heading into the flu season. Mm-hmm. And by that, I mean the viral winter respiratory season.
Right.
So October-ish. October and November. I would also clearly say, if you had COVID, wait that 90 days. I will be getting mine like 80 days from whatever this is. So that's it. And the only other thing I say, though, is that the longer you're not getting that booster, you're still a little more at risk. So for each patient or person, I'd probably almost have to have an individualized discussion.
Dr. Brooks, I certainly am appreciative that you took your time to be with us today and give us this important information. And I'd love to have you back and discuss more.
Right.
And if you can stick around, this is going to be a most interesting talk. He blew away.
Dr. Maxey?
Yes.
Dr. Maxey, before we move on, Dr. Brooks mentioned Dr. Sherrod when he came on. And Dr. Sherrod put her hand up quite a while ago, wanting to say something. So I wonder if we could recognize her for a moment.
Okay, Dr. Sherrod, if we got a short question, because I do need to move on.
Yeah, I just want to commend Dr. Brooks for his work on the ACIP and for being able to deal with this very complex, difficult situation. And I understand the shoes that you're in. My question, I think I'm a little bit confused when Maxie showed the slide of the number of infections prevented by COVID vaccine, when we had actually been under the impression that the vaccine itself does not prevent infections, but it mitigates the severity of the illness in patients once they get the infection. So just kind of wondering where that data came from, and because that kind of confuses people. And I know that NMA was requiring that everybody be vaccinated in order to attend the conference. And Barbara, it's good you didn't go to the pediatric section. I've had several colleagues who got infected after the convention in the pediatric section of the NMA. So my question is there data on actually a less chance of getting infected if you're vaccinated? And the other question I have, what is the long-term effect of boosters?
Dr. Sherrod,
right.
If I can do this in terms of executive privilege, we've got a major presentation that I want to make sure we get, and that's—
we can talk about it later. He doesn't have to answer it now.
I'm going to make a quick comment. The vaccine does prevent infection, and there is data that shows, and Randall presented some, and there is others, because you can just compare cases to vaccinated versus unvaccinated people. But it prevents some infection, but it's not. I mean, we stated that aspect of it. That's not why it was developed. And the long-term effect of boosters, I mean, we don't know because the boosters have only been around, what, a year? So, I mean, you can't say the long-term effect of anything if it's only been around a year. But we do know the long-term effect of COVID already and getting COVID, and it's bad. Thank you very much for your time. Dr. Max, I think I'm going to hang on. I mean,
Okay.
you know, I'm a pediatrician. What I heard is coming next. I'm listening to. But I'm going to mute myself and just block my camera and just be a fly on the wall.
Thank you so much. And maybe Dr. Walks, we can have another meeting with your committee and make sure Dr. Brooks is on it on a Wednesday night. But I'd like to, Simon, if you can put up the slide to introduce our guest speaker, Dr. V. So,
Dr. Maxey, did you want me to read this whole thing?
no, if you could just extract the key relevant things.
Okay. First of all, let me say that all of it is relevant. Dr. V is incredibly certified and licensed and all of that. He's licensed and maintains a private practice in pediatric school neuropsychology in Miami, Florida. He's a consulting school psychologist and vendor to the Miami-Dade Public School Office of Vocational Rehabilitation, Children's Medical Services Office of Child Find. He's a lead analyst and applied behavioral analyst for children with severe neurobehavioral and developmental disorders. Dr. V is a former diplomat of school neuropsychology. Dr. V is an author of Gray Matter Matters, Reflections on Child Brain Injury and Erroneous Educational Practices. He provides scientific evidence through case studies that children with emotional and learning difficulties are those with underlying neuropsychological problems. Dr. V has published a second book entitled Misbehaving Brains, Essays on Good Children Who Do Bad Things in School. Dr. V has really been a myth buster with some of the preconceived notions of children, especially children that have problems with expected behavior in structured settings. So Dr. V, I know I left out a whole lot, but we want to get to you.
Okay.
So,
Dr. Walk.
And sir, anything I left out that really was important, please tell us.
You know what? I want to say this, Dr. Walks. You know, Dr. Maxey is my friend, but I'm beginning to love you.
You know what, Dr. V, it is okay if you like me better than Dr. Maxey, because my mother likes him better than she likes me. So it's okay.
Okay, I'm gonna, hopefully you guys can see the screen.
Yes, sir.
Can you all see it?
Yes.
Okay, great. That's what I want. That's what I want. Okay, so let's do this. What I wanted to do is, let's see, slideshow from ending from current slide. Okay, though. All right, so thank you so much, Dr. Maxey. Again, I appreciate these lectures. I appreciate being part of this forum. And it truly is a very humbling experience for me. It truly is to present before colleagues and community stakeholders and so forth. And this information that will be presented, hopefully it will give insight into current practices and how we look at 21st century neurobehavioral patterns in the light of the recent school shootings and the level of violence that we see continuously. So again, I want to say thank you so much to Dr. Maxey and to Dr. Walks and to all who have invited me to this important forum. So today we'll look more closely at the part 2 of the neuropsychology of violence. Specifically, I'm focusing on psychiatric versus neurological presentations because it truly is a thin line. And I think that will become more evident as I show you or present some research findings that will show that it is a very, very thin line when it comes to presentations of a clinical nature. And so without asking the right kinds of questions, we can miss children and adults who may apparently seem like these are psychological problems, when in fact there are neurological ones as well. That being said, so let's take a look at the region of the brain. As I mentioned before in the first presentation, I didn't have many slides. I added some more slides today. In fact, I actually modified this program, this lecture today, so that it can be perhaps more meaningful because I have more slides. And you know, Dr. Walks, I even have a slide for you. And when I get to that slide, I'll make sure I mention your name. It's just for you. Okay, so let's talk about current slide. It's here. Okay. Hold on, maybe that's not the right one. Okay, let's do this. Oops. Okay, hold on 1 second. This might be here. Okay, here we go. Okay, so we'll do okay, so here we go. All right, so the area of the brain that I'm going to be discussing today, as I have done in lecture 1, would focus on specifically the frontal lobes and theoretically discuss executive functions, because as you will see later in the slides, you will see why this region of the brain is so critical regarding neurological and psychiatric problems. And so the frontal lobes basically is a region of the brain, evolutionary wise, it was the last to develop. And even today, when we look at the brain development, we see that the frontal lobes continue to develop well into your 40s. It's a region of the brain that manages other areas of the brain. So we take a look at the temporal lobes or the parietal lobe or the occipital lobe and so forth. What the frontal cortex does, it integrates information from other regions of the brain, and it has to make critical decisions regarding output. So when we conceptualize the brain as an organ that's responsible for producing behavior, it produces behavior because it has to integrate or receive information from other regions of the brain, and then has to decide what actions to take. The orbital frontal region of the brain has been theorized to house what researchers call executive functions. And as you can see, that this is a really important part of your brain because it involves abstract thinking, planning, self-monitoring, self-control, working memory, divided attention, sustained attention. Now, when we're dealing with children with attention deficit disorder, which is a misnomer because typically when children are diagnosed with attention deficit disorder, the assumption is that all children have the same disorder. In the DSM-5, even though the DSM-5 separates, or for an example, it distinguishes between children with ADHD with hyperactivity, impulsive behavior, and ADD, children without hyperactivity. Well, when from a neurological perspective, it's even more complicated than that because there is divided attention. For an example, there is sustained attention, there is visual attention, there's auditory attention. So therefore, when children are diagnosed with ADHD, we have to be very careful that we specify exactly the time of attention that's problematic. Processing speed, initiation, sequencing, set shifting, which is problematic for individuals with frontal lobe problems, particularly children with developmental disorders, because for an example, the child with autism will have significant problems with set shifting. They cannot shift set. For an example, if they engage in one particular activity and when that activity changes to another activity, they have difficulty moving from one task to another task. Cognitive flexibility has a lot to do with the person's ability to look at a problem from different perspectives. They tend to be focused on, minor issues. So for an example, in a relationship situation, a person may become argumentative because they're not able or willing to look at another side of the problem. And that limits your problem-solving abilities, basically. Planning, really, really critical for this particular reason, because we have to plan out our lives. We have to plan what we're going to do for the day or for the week or so forth. So the ability to project ahead is critical. And this region of the brain, again, is the area that we're going to focus on for the second part of this lecture. Now, when we take a look at some of the personality, psychological, psychiatric changes that we see with frontal lobe injury, you can see that now we begin to see overlap between, say, psychiatric issues and neurological issues, because they're basically the same. Exhilaration, for an example, childish behavior that you can see in some schizophrenic syndromes, lack of restraint that you see with personality disorders, conduct disorders, anxiety, restlessness, decreased concern with propriety, social withdrawal that we sometimes often see with people with depression, purposelessness, another indicator of possible depression, irritability, what some lay people call brain fag, which is basically slowness in thinking, apathy and indifference, inertia, decreased self-concern, and so forth. Again, when you look at these problems and when these individuals present themselves clinically, it is really important to be able to rule out whether or not there's been any type of history of brain injury, simply because we know, for an example, that past brain injury, particularly traumatic brain injury, that has been forgotten. And I work in the school system primarily because, honestly, I did my hospital thing, I did rehab centers and so forth, but I never knew, for an example, that the educational domain was such a right place for the identification and the early identification with children with neurological problems, and it allows me as a psychologist to be able to go into as early as 3 and 4 years old in the preschool programs to help identify these very early neurological problems. So I'm working on my third book at the moment. Hopefully it'll be released next year. And I'm focusing specifically on early childhood education, specifically because early childhood educators are really missing what I call soft neurological signs that later on manifest into significant learning and emotional problems. This is an example of some patients who had frontal lobe injury. I won't read these to you, but this is an example of some individuals who had so-called personality changes after they had frontal lobe damage. You can sustain frontal lobe injury in a number of ways. I don't have time to get into those different ways, but you can have developmental anomalies. You can have traumatic brain injury. You can have bacterial or viral infections, including COVID. I just did a lecture at the university just last week, and we were talking about COVID and what researchers found regarding COVID, at least the initial COVID pandemic. And what researchers found is that not only was the virus loaded in the airways, in the lung area, but what they found was they found a greater load in the nasal passages, which kind of interesting, because then that would explain why individuals lost their sense of taste and smell, which clearly pointed to neurological events and so forth. So again, these are just some of the examples. Case number 2, if I had something to say, I can't wait, and I have to say it straight away. Issues of impulsivity, Case number 4, emotion, tears, that's all gone out of the window. If I saw somebody cry, I would just laugh. People look really silly, getting upset, so forth. These are just some examples of how you can have these drastic personality changes as a result of frontal lobe injuries that can be mistaken for psychological or psychiatric problems. Once again, when we take a look at violence and aggression, again, the region of the brain that we concern ourselves with it is the orbital frontal cortices, left and right frontal cortices, and of course the limbic structures. These are subcortical regions, and the pathways, we're looking at pathways that lead from the amygdala, for an example, into the frontal lobe, because as I mentioned last time, you can have damage to the frontal lobes structurally, or you can have damage to the amygdala structurally, but you can also have damage, personality changes, if the pathways between the subcortical regions connect with the frontal regions, you can have that as well. This is why the new technology, diffusion tensor imaging, is very, very important, because it allows us now to look at white matter tracts in the brain that, if damaged or some type of development anomaly, can also account for personality changes and so forth. When we take a look at criminals, there's many studies. I only mentioned one. I told Dr. Maxey that I will have a list of references for you. I put 2 at the end of the slide, which I think has much information for you to really go into these situations, take a look at the evidence that's already there, the science is already there, that individuals who commit violence are individuals with brain damage, and they found that the frontal lobe, specifically frontal lesions, are associated with aggressive control. And once again, the jury is out regarding the specific region of the brain that we concern ourselves with. The orbital frontal lesions is the area of the brain that's been most implicated, and impulsive violence is more likely than predation if this region of the brain is damaged. But we must also be careful to say that frontal lesions in and of themselves do not, and I want to repeat, they do not predict violent crime. However, it may increase the likelihood of a person committing violent crimes within a specific population. I put this up for Dr. Walks because of his beautiful analysis when we spoke last time about the issue of environmental factors, and this is a brain scans of an individual with lead damage, with lead poisoning, if you will. And what we found is that individuals with lead poisoning will have brain damage, and the area of the brain, as you can see, that affects the most are the frontal lobes. Specifically, the same region that I've been talking about before, the orbital frontal region of the brain here is the most affected. And you can have not only incidents of aggression, you can have lower IQ scores, you can have conduct disorder-like problems, you can have depression, and it would just take me much time to just talk about the frontal lobes itself. It's a very, very important region that we're just beginning to better understand its functionality due to the medical technology that we have available today. Once again, this is a study out of England that showed the brains of individuals who commit. This came from an individual who was a serial killer. And what they found with this individual was that he had a history of violence, had a history of committing murders. And what they did was they put him on trial, and he was on. He was being put on trial to be put to death because of his criminal activity. But what they did was they did something interesting. They wanted to image his brain. To see whether or not he had very good attorneys, and they pushed for brain scan in this individual. And what they did was they scanned his brain, and what they found, again, was something very interesting. Take a look at the images on top. You'll see that this is his brain. And if you take a look at the images on the bottom, these are nonviolent offenders. And you can see, for an example here, when I'm pointing the mouse, there's a tremendous reduction of brain activity in the frontal regions of this individual's brain. And basically across the board, if you look at the brain, the images on the bottom of the brain, at the image at the top, once again, you see tremendous hypoperfusion, if you will, within the frontal cortex. And this is a critical area of decision-making and planning and impulsivity and so forth. And you see there's such a tremendous reduction in metabolic activity within the frontal region. And this individual said, he claimed that he just lost his impulsivity. He would just murder for no reason. He wouldn't think twice about it. And once again, this is some evidence that shows it again. The limbic system, as I said before, I won't read all this to you, but basically we're saying that subcortical region, specifically in the limbic system, there's an almond-shaped organ within the limbic system called the amygdala. And it is there that we believe that people with violent behaviors have the most difficulty, because these individuals consistently show either pathway deficits or structural deficits to the amygdala itself. And once again, the research have shown that violence will occur when inhibition to control. We all have the ability to self-regulate our behavior. Okay, we're in a traffic jam. We want to get to a meeting and we're stuck in traffic, and we get upset because we want to get to the meeting. So what do? We'll turn on our radio. We'll just calm ourselves down. We'll make a phone call just to take our mind off situations. Well, if you have a pathway problem between the limbic system, specifically the amygdala, into the frontal cortex, you would just blow up. And some people have done that. Some people, what they call road rage. Some people with road rage, again, once we rule out the psychological and the psychiatric, then we have to take a look at the brain itself, because that could be a potential problem. Okay, so, all right, so Mama said a picture's worth 1,000 words. So let me just show you this region of it. This is what I mean by a pathway issue. This is a diffusion image, which we now have available to let us see, for an example, white matter tracks that link one region of the brain to another region of the brain. In this particular image that you're looking at, we're looking at the uncinate fasciculus, and the red organ that you're looking at here, this is the amygdala, and the blue area that you're looking at is called the uncinate fasciculus. That is a pathway that leads from the subcortical regions into the prefrontal cortex. Once again, you can have damage structurally in a minute when I talk about traumatic brain injury in a minute, but you can have structural damage to the prefrontal cortex, or you can have damage to the amygdala itself, or the third is you can have damage to the pathway that leads from the amygdala into the prefrontal cortex. So with diffusion tensor imaging now we can now take a picture of the brain and examine white matter tracks that also could be implicated as well. But you probably most likely will not be able to get these images in the hospital, more likely in a research hospital, specifically in a medical school or some type of scientific center. When I studied at the National Institute of Health, they had this technology available that will allow us to take a look at a person's brain in great detail. Individuals with dementia, we take a look at neurological diseases. Dementia individuals with frontal temporal dementia will lose their ability for moral behavior, so they may engage in activities that are clearly immoral, that they wouldn't do otherwise. What psychologists call sociopathic behavior, once again, there's a very thin line, because you can have sociopathic behavior from faulty parenting, poverty, as Dr. Walks said last week. Environmental factors can most definitely play a role. However, my thing has always been, and will continue to be, Fine, let's take a look at the family environment. Let's take a look at the community environment, because as I said before, children who are exposed to violence, children who are exposed, not victims of violence, but children who are exposed to violence will have brain damage as well. So my thing is, let's rule those things out. And when those things are ruled out, now it's time for us to take a look at the brain, because that, in fact, is where the problems are. Once again, this slide again is for my friend, Dr. Walks, again, showing you very clearly that the interaction of biological and environmental factors on aggression and violence can happen. Brain structure and function. Remember, when a child is born into the world, the child comes into the world with that's biologically intact, if you will. However, the brain continues to refine itself from the child's interaction with the environment. Well, in the book that I'm writing now, I lay a strong argument between the first and second environment. The first environment, of course, is the mother's womb. That's where the child is. I mean, that's where the child begins. And so we have to be concerned specifically in the first trimester of pregnancy. The first trimester of pregnancy is very important, as I was telling my students last week, because the brain, by the time the mother knows she's pregnant, the brain is already developed. The neural tube has already been established, and brain development is tremendously. It's a very, very rapid time. So if it's an unplanned pregnancy, if you will, if she doesn't have good prenatal care, then there's a possibility that some of her actions could have a negative impact on that infant. And in this particular case, I'm only going to mention alcohol, because alcohol is a neurotoxin, and it can have a devastating effects on that developing nervous system, specifically in the first trimester of pregnancy. We know, for an example, that and this may be controversial for some people, but the science is the science. And in my book, Misbehaving Brains, I pointed out that it is possible for you to be born with a bad brain. A person could be born with bad liver, a person could be born with bad kidneys, but it seems that when we come to the brain, it seems like we overlook that particular organ. But it is possible that developmental factors caused by genetic anomalies can cause faulty brains. So once again, we take a look at the interaction between biology and environmental factors that can contribute to violence. Another picture for you. This is this is another murderer. This person his name was Antonio Bustamante. They spared his life. He was another person put on trial. It was found they were looking to take his life because he was a serial killer. So they imaged his brain, and what they found are the images that you're looking at now. The image on your left is an image of a normal brain, and if you take a look at the image on the right, that is his brain. So, and you can take a look at the lack of red and yellow on his brain scan. Let me just point this out. This again. Notice on the normal brain, notice very good metabolic activity in the frontal region. And we take a look at his brain, it's almost what we call hyperperfusion. In the prefrontal cortex, there's almost no activity. When you see a slide like this, right away, you have to concern yourself, because without metabolic activity or good blood flow to the frontal region, then you can see that the person lacks or will lack the ability to regulate his behavior or his emotion, and so on and so forth. Sometimes we see this with children with ADHD. If you take a look at an image with a child with attention deficit disorder, it's almost the same profile, specifically with children with attention deficit hyperactivity disorder without impulsivity. The frontal regions of the brain tend to be underactivated, if you will, and the child loses his ability for impulse control. In fact, children with attention deficit disorder with impulsivity are at higher risk for traumatic brain injury. These slides, these slides very quickly. These I think were shown last time, I'm not sure, but when I said you can't always predict because a person has a brain injury, you can't automatically say that a person is going to be violent. On the image on the right, this is a woman with bifrontal meningioma, as you see, this large tumor mass, and she was never violent. On the other hand, here's a man with advanced Alzheimer's disease, and he was he was so violent that he needed over 40 medication trials just to regulate his violent behavior. So you can't always tell by looking at a brain scan, for an example. Here's another person with a lesion after traumatic brain injury, and you can see the lesion clearly here and here within the temporal lobe. And once again, this person was shown some violent features as well. So sometimes you can, sometimes you can't. And this individual also had very serious brain injury after a traumatic brain injury. And once again, he was never, at no time he was violent. So this is why you have to be very careful when you look at certain brain images. This is a very interesting slide that I put in for you, just to let you see that there are specific, this is a PET image of a person reading, and this is one of the beautiful things that we have about.
Can you define PET?
PET, yeah, these are positron emission tomographies, and we're looking at a in vivo activity of a person hearing words, seeing words, speaking and generating words. And you can see the different regions of the brain that are active during that process. And again, here's another, this is from a functional, an fMRI, these are functional images. Again, you will not see these images in other words, if God forbid if something happened to you, have some type of brain injury, they will not take this type of image of your brain. They will just do a regular CT scan or MRI, but a functional imaging are usually reserved for medical research centers. Here we're looking at this person. This is a normal brain image, but what you're seeing is metabolic activity of a person that's performing a decision-making task. And when I mentioned before about the frontal lobes being very, very important for decision-making, you can see there's a tremendous amount of metabolic activity in the frontal region. This is taken from the psychiatry and clinical neuroscience. This is an image of 17 normal young adults, and we're looking at activity in the right dorsolateral prefrontal cortex, where the individuals are doing a go no go task. This is a neuropsychological test which measures impulsivity. Now you look at this little yellow dot and you say, wow, it's really not a lot of activity. Well, you won't see this in adults, but if this was a child, you'll probably see a lot more activity, simply because the brain works in a reductionist fashion. So in the beginning, when you're learning new things, toddlers, preschoolers, early elementary children, if they're involved in a reading task, for example, we see tremendous amount of activities bilaterally. However, once the person masters that particular skill, then the brain reduces its energy to very small regions in the brain, because the brain says, okay, we have this now, we have this, and so then it only takes a little area. So even though even though it doesn't look significant on this slide here and here, the person is able to show that he has lots of impulse control. And once again, we see it is within the frontal cortex, and this is on the left side. Actually, this is the left side of the person's brain. Okay, so briefly, because my time is always limited, but okay, that's okay. That's why I was making an effort to try to take these slides and just consolidate them as best as I can. I really have to talk about traumatic brain injury. I see lots of those cases in schools. I'm working with a child now who has had a history of she was involved in a motor vehicle accident, traumatic brain injury. She's having all kinds of problems learning in school, behavioral problems, emotional events, and so forth. So just a brief overview of traumatic brain injury. Basically, two types of traumatic injuries. You can have a penetrating injury, or you can have a non-penetrating injury that are basically can result in traumatic brain injuries. So non-penetrating, these are more prevalent in civilian populations. Penetrating means, basically with the veterans. I mean, anytime a person has been shot in the head and doesn't die, or a person has been involved in a war situation where a bomb blows up and he gets trapped. Like my dad was, and I didn't notice until in fact, I never knew my father had traumatic brain injury until I was into my program. My father was a war veteran, and he was injured pretty badly, actually. He ended up with a metal plate in his, and I want to say in his left hemisphere, in the left frontal lobe. And my mother would always tell me, she would say, your father was the sweetest man. He was so loving, he was so kind. But she said after they put the metal plate in his head, she said he changed. My dad became very, very violent. He became apathetic. He became depressed, and he became a chronic alcoholic. I mean, my father drank very, very heavily. This was after the injury. Now, during that time, when veterans had sustained head injury, the treatment protocol at the time was to stabilize the patient, and then they would be released. At that time, we did not know that there could be subsequent behavioral sequelae that had to be addressed. The behavior sequelae I'm talking about speaks to emotional changes, personality changes, aggression and violence and so forth. And honestly, my father had all those. I was afraid of my father when I would go visit him, because he would change in a moment. I mean, you would be sitting there talking to him, and then all of a sudden he would become so angry. And if you take a look at the final bullet, you see both are relevant to the neurobiology of aggression and violence. And I can say that was the same with my father. My father was changed significantly. So I think my interest in neurology and neuropsychology, it strengthened me, because I wanted to be a pioneer to address, brain injury as being fundamental to our understanding of neurobehavioral disorders, because we're still not paying enough attention to the impact of neurodevelopmental and neurological disorders. And this is the gentleman that perhaps started it all. This is Phineas Gage. He had a penetrating traumatic brain injury. He was working on a railroad line, and he had one of those machines that one of those machine hammers that drove the spikes into the railroad. Well, his blew up on him, and this is his bust. This is his actual bust of where the talon iron went through his jaw and it penetrated his brain. And after and he lived, by the way, this gentleman lived. And once again, after the injury, there was significant behavioral changes with him. He was described as being very soft-spoken and kind to people prior to the injury. But after the injury, he lost his, he was disinhibited. He was very poor planning. He began to drink, very poor decision-making. And some of his clinical presentations mimicked as if he had schizophrenia, because he would laugh at things that were very serious, or he wouldn't take life serious and so forth. And there is a saying in neurology, touch the brain, never the same. So if you had any type of head injury, you're going to lose some ability, depending upon your age. Now, if you're a child, I could speak to pediatric neuropsychology maybe at a later time. but there is a difference between clinical presentations in children with traumatic brain injury versus adults with brain injury as well. So I won't spend a lot of time here. I just talked about this. This was a study done by Gaffman in 1996. I gave his reference at the end of this slide in the Journal of Neurology, where they looked at veterans and they found that veterans with penetrating wounds, again, these were veterans from the Vietnam War. These individuals had a higher frequency of aggression and violence as opposed to the control group. So he wrote a very beautiful paper on addressing this problem as well. And if you take a look at the third bullet, you see the studies that shown that between 20 and 49% of children and adults had agitation and aggression within 1 year post-injury. Now, this is significant because in the school system, children, particularly Black children and boys, I should add, if they show signs of aggression, the first one of the first keys is to expel these children or expel these children from school. And we're seeing an alarming rate of children being expelled from programs. It is very alarming that children are being expelled from preschool programs because of their aggression in the preschool. Well, what does this mean? Well, it means that we're not doing a good job in identifying those children by not having thorough, say, developmental histories from their parents that could give us a key as to why that child may be having these type of difficulties as well. So not only do we want a pediatric evaluation, but we also like to have a pediatric neurological assessment because we want to at least have a baseline of their child's developmental factors. Okay, so on with traumatic brain injury. These are contusions. Contusions are bruise to the brain, for an example, most likely damage to the frontal and temporal lobes. And you could, once again, can have psychiatric type changes, psychological changes. And two of the prevailing behavioral sequelae from frontal lobe and temporal lobe damage is disinhibition and memory loss. And just some slides that showing this is the type of brain injuries that you can have. This is a normal axon. This is an axon that has been damaged. And this is one that has been a post-traumatic condition where you see, for an example, that the person will still have some deficits as well, because you see, for an example, that the release of neurotransmitters in the synapse is just typically broken off, or the connection is not made altogether. You'll see these type of injuries in a rollover. So anytime you see the person is involved in a motor vehicle accident and there's been a rollover, it's likely this type of injury that you see here in the middle. These are more serious because when you see this type of injury in a person, what happens is that connections begin to be torn or stretched or what have you. And so these type of injuries result in diffuse brain injury. This is perhaps the more serious type of brain injury that you can have during a rollover. This is a coup contra coup injury where the patient, let's just say this is a motor vehicle accident, the person has to stop suddenly or she runs into something, immediately the head goes forward, the brain is damaged in the frontal region, and then the neck snaps back violently, and here we have another injury. So a coup injury means an injury that occurs just in one region. A contra coup injury is an injury that occurs not only in the frontal region, or it also involves, in this particular case, the occipital region or posterior. However, you can have it from side to side too. You can hit your left side and your head can be violently shaken to the right side and your brain squashes against the right side. Now you have injuries on both sides of your brain. Okay, very briefly, healthy brain in a person with traumatic brain injury. I won't read all these to you. I'll just leave up here for a second so you can see some of the problems that you can have when you have a traumatic brain injury. And you can take a look at the different regions of your brain, if you will, and some of the clinical or behavioral sequelae that you can have as a result of these type of injury. frontal injury, lack of focus, irritability, language difficulties, and so forth. Brainstem injuries are really more difficult and more dangerous, particularly because these are your life regulating centers. Changes in breath, difficulty swallowing, and so forth, loss of consciousness. Cerebellum injuries are really important because you can be mistaken by being well. There was a story I read about this gentleman who was pulled over by the police because he was driving erratically. They gave him a sobriety test and he failed, and they locked him up. And 24 hours later, he was dead. And they did a post-mortem on his brain, and they found that he died not because he was drunk. He died because he had an injury or a blood clot in his cerebellum, and that caused him to lose his coordination. And they found out too late. Once again, psychological factors. Again, I won't read all these to you. Individuals, I know you're probably bored with all this bullet stuff, but you can see, again, these are psychological factors. Again, and my thing is, as I've been saying from the very beginning, yes, please rule out medical issues. Please rule out environmental factors. Definitely, you want to rule out psychiatric or psychological. But my thing is, and will continue to be, once you rule those things out, you need to examine that child's brain, or you need to examine that individual's brain. Psychiatry is important, psychology is important, pediatricians, and whatever specialty in medicine, you're all very important. However, we're still in the behavioral realm, we're still not paying much attention to the brain. And that's why I have dedicated my life to pursuing this issue on finding out the issues with these children. I just want to leave this up. I'll just leave this up for a second. For those of you who are interested in pursuing, looking at violence in the brain, here are at least 3 references that you can definitely check out. And by the way, these are my favorite, particularly Grafman and others when they did their study in the Vietnam Head Injury Project, which was done back in 1996. And during this time, Congress was pouring billions of dollars into neuroscience. They call it the decade of the brain. And then Seaver, in his article, The Neurobiology of Aggression and Violence. This was done in 2008 from the American Journal of Psychiatry, and Solberger and her colleagues looking at personality changes and diffusion and psychopathology and the specialized inpatient programs for borderline personality disorders. And what they found, again, was significant neurological problems in patients who were thought to believe to have psychiatric problems and not neurological. Thank you very much. If I went too fast, please forgive me, but Dr. Walks and Dr. Maxey always pushes me through this process, but it's okay. I still love them anyway. But thank you very much.
My only comment is, wow. This has been so interesting and so good. And hopefully this will be a series that you'll have and come back and visit us. And just to start off the questioning, is there a legal implication to identifying some of these frontal lobe and white matter brain defects?
A very good question. That's a very good question. And for the Black community, I'll address that, because in the Black, the advocacy in the Black community is quite lacking. We need advocates to empower those in our communities, to let them know that there are different levels of analysis to understanding a child's behavior problems. And as a practitioner, I try to avail myself as much as possible to spreading the news out there for parents by advocating that to push the neurological side, to take my reports to their neurologist and have them do a comprehensive workup with the child. I think you guys heard me say this many times. I'm very, very much into neuroimaging. I want to see MRIs. I would love to see functional MRIs, but for the most part, CAT scans, MRIs, and my baby, as you all know, the quantitative EEG gives a beautiful clinical presentation of what's going on with the child. As I said before, yes, you want to rule out psychological factors. Yes, you want to rule out environmental factors, but this is where our parents get lost, because they get lost in this process. And let me explain. For most parents with children with learning problems or behavioral problems and so forth, for them, the end road to them is typically the psychologist or the pediatrician. And I have a tremendous respect for pediatricians and psychologists and psychiatrists. However, that's not the end of the story, because we're still fundamentally leaving out, an area of the body that's the one that's responsible for the behavior in the first place. So I push very hard as I can by saying that the brain produces behavior. You cannot separate behavior from brain function. And when that message is conveyed, I think that more of our children will be identified much earlier. We're seeing it in pre-K programs. As I said before, children in pre-K programs are being expelled from school. And so what are we learning about that process, Dr. Maxey? What we're learning about is when we do a comprehensive developmental history, we're finding these biological markers, if you will, either in the antenatal period or in the postnatal period. Most times when the child is sustains, I would say most brain injury in the pediatric population will sustain brain injury postnatally or during the delivery process. Breech birth, children who are born with the umbilical cord wrapped around their necks, for an example, children who were delivered through by forceps or through suctioning, and these events are typically overlooked and sadly, by the time the child goes to school to learn, and when a child is challenged, and preschool programs are, I hate to say this, but they're just inadequate, quite frankly, because teachers do not know enough about neurodevelopmental issues, in some cases, developmental issues, and these children are passed on. Look, I have a child now I'm working with right now. She's a beautiful baby. She's 9 years old. She was already retained. She just made it out of second grade. And she has a condition called, word blindness. And I really love to talk about these things at some other point. And basically what it is that she's perceptually blind. She cannot read because she's perceptually blind. Now, she can see letters, but she can't see words. If you ask her to write her name, she writes it from, from right to left, and she writes it backwards. Now, many will mistake this as being dyslexia, because many people believe that dyslexia is a visual disorder. Dyslexia is not a visual disorder. Dyslexia is a language disorder. Again, I don't have time to get into that, but at some point I can explain what that means. Just because a child reverses letters, it doesn't automatically mean that they have dyslexia, because normal children will reverse. But in her particular case, when I examined her last week, she would not attempt any task that she felt was too hard. And so I asked her to identify some letters, and some she identified and others she couldn't. But when it came to a word, she was completely blind. She couldn't see it. She couldn't see the words.
So Dr. Neighbor-Stevens, Dr. Walsh, and Dr. Hines, and if Dr. Oliver Brooks is still on, you guys see any questions in the chat or have any of your own that we want to address to Dr. V?
I have a bunch of questions And I'm going to jump in because the kind of questions you're going to get into will take us to the end. But from the pediatric point of view, and I realize you were very truncated in what you could cover in today's session, but with the begrudging acceptance of CTE in adult football players and and boxers and other athletes, have you seen any evidence of concern beyond those of the pediatricians around children participating in sports that could lead to head trauma?
I would love to see. I'm very proactive in my field, and what I would love to see. I've actually volunteered to do baseline testing for children in contact sports. What we're seeing now is we're seeing CTEs in younger individuals. I mean, I think I recently saw a study where a college student died of CTEs. And once again, you said, well, how can that happen? He was so young, he really didn't have many head blows. Well, he played football for a long time. So when you take a look at that's why history taking is so important. So he had many concussions. And as a result of that, we know that concussions are cumulative, which CTEs are. CTEs are cumulative, is a cumulative result of head injury. And so the more brain contusions you experience in your career, the more likelihood that you'll have a CTE. And not only a CTE, but sometimes we'll find other factors, as I mentioned as well. For an example, white matter, deterioration, where you have pathways issues now from the limbic region to the frontal cortex. You will have, particularly with boxers and boxers who sustain head injury, we see speech delays, we see memory problems and so forth. And quite frankly, the more contusions, the greater the probability of some type of dementia later on in life. But the surprising thing is that we're finding it is happening even in younger people.
Dr. Walks?
Oh, Dr. Neighbor-Stevens and Dr. Hines both leaned forward. So I'm going to let them go ahead and go first. And then I definitely have a question, but go ahead, Dr. Hines.
So I have quite a few questions. And this one I will ask as the parent of a child who has several of the diagnoses that you mentioned, but we've never had any brain imaging, right? My son I have a 7-year-old, he's got ADHD, he's got dyslexia, he's got a sensory processing disorder. I could go on. But my question is, if you're talking about kids and brain injuries and things like that, how would you suggest thinking about these things in a young person in a way that is not definitive, that doesn't say this is who you are, right? As opposed to these are the results of these tests, of these studies.
Well, one of the things is we're not paying a lot of attention on rehab. And sadly, we're labeling these children as if these labels mean it's the end of the world for these children. And quite honestly, that's not the case. You're probably interested in my book, Gray Matter Matters, because I addressed that specifically in my book about dyslexia being a death sentence for children. It isn't. My concern about dyslexia is the fact that there are different kinds of dyslexia. And unfortunately, if your child has been diagnosed simply with dyslexia without you understanding the type of dyslexia that he has, then the interventions, I'm afraid, will just frustrate you and him even more because they haven't identified. There are several subtypes of dyslexia. I don't have time to get into those right now, but let's get that straightened out. The second thing let's deal with is attention deficit disorder. Once again, what kind of attention deficit does your child have? As a neuropsychologist, I would be very interested in knowing the type of attention deficit that he has. Now, there is, unless your child has had a thorough neurological evaluation that someone will that someone can refer to ask the type of questions that neurologists will typically like to see, then they can then provide the diagnostic workup that will answer the questions that you have. For an example, in my particular case, I love to see pictures of the child's brain, and I'll also like to see an EEG profile, because EEG profiles is a beautiful diagnostic tool that can give you the subtype of attention deficit disorder that your child has. And then finally, as a rehab system, in my practice, I use EEG neurofeedback as a tool to remediate children with attention deficit disorder. There's so much research out there that shows that the neurofeedback is a very effective way of not only reducing the symptoms of attention deficit disorder and seizure disorder, but they can, and at times, eliminate that child from having that problem as well. I've had a child I work with. She was in Miami. I worked with her for 6 months. When after treatment, her symptoms of attention deficit disorder left, and she's in New York now. She's doing really well. And her mother's, even today, her mother says she doesn't see those symptoms anymore. So it's very effective. It's a very effective tool for rehab.
Yeah. Dr. Walks, is there anything in the chat as well as your questions?
There's a lot in the chat, Dr. Maxey. I know we are near the end of our time. Maybe Dr. Neighbor Stevens or Dr. Hines can pick out one thing each out of the chat that we can get to. Let me say that Dr. Brooks did put a message in the chat that he thoroughly enjoyed the presentation. He stayed until the end of it, and then he had to run. Let me say this, Dr. V, just magnificent is the only word that comes to mind. The information that you've given us is so important and so relevant to our communities, where so often, number one, we don't understand the value of special ed, of getting our kids into special ed. We are the ones who are trying to say, don't you put my kid in special ed, and the parents who don't look like us are knocking each other down to get their kids in special ed, because they understand the resources that can be available if a child is in special ed, is not labeled, but is helped. My statement is, Dr. V, you gave a lot of doctor level information. And I think the one thing that I got out of it is that as a parent or as a grandparent, we just have to advocate for our children getting access to the kinds of resources you're talking about. I don't have to know what all the words mean. I just have to know that my child never got an EEG, my child never got any imaging, and you're labeling my child as this or that. That's enough for us to advocate for something else for our child.
Yes,
and then I think the second.
Yes, I'm sorry. I'm sorry. I want to stop you there, because what you said was very significant. And that the statement that you made, stop right there. That's my fight. That's my battle. Because a lot of things we do for our children, we stop right there because we don't have the information information available to take us to that next level. I'm sorry, Dr. Walks.
No, Dr. V, you're right on point, because right after that, when we tell people we want more, we have to be able to tell them what. And so folks like you who have written books that the way you responded to Dr. Hines with, my book covers this. Those are the kinds of things we need. We need to be able to say, after we say, hold it, my child didn't get this. Well, what is it your child needs? We need the information. So again, I want to thank you for sharing it with us in a way that, at the Dr. Neighbor Stevens and the Dr. Hines level and the Dr. Sherrod level, they can understand all those medical terms. But even at the level of someone that doesn't understand all those medical terms and psychological terms and neuropsychological terms, they can know that there's something else other than we looked at your child for 3 hours and we can tell you exactly what's wrong. We can say no.
Yeah.
My question for you is this: when we do advocate and we get the information, I think you're in Miami-Dade in Florida. Are there colleagues of yours in Los Angeles, in Baltimore, in Kansas City, in Nashville, that are able to give the kind of comprehensive interventional interventional diagnostics that you can give?
That's a good question. I would say your line of offense would be the psychologist in the school, your pediatrician, your neurologist,
Yeah, you on?
and your neuropsychologist who specializes in biofeedback. So someone mentioned, I don't know who mentioned this the last time, but it was really important. And the question centered around the knowledge of neurofeedback and what it does. And as I said before, what's really missing in our communities is the lack of knowledge that these things exist. Look, there's nothing wrong with special ed. I will definitely advocate for special education. My fight with special educators is that special educators are lacking the knowledge of brain-based interventions because they're treating neurological problems as academic problems. They are not academic problems.
Right.
A child with dyslexia does not have an academic problem. A child with a dysgraphia or dyscalculia or whatever, those are not academic problems. Those are neurological problems. And because they are neurological problems, they need a brain-based approach. And what is a brain-based approach? A brain-based approach is not just simply paper and pencil. I think some parents, I think some people are frustrated sometimes by psychological evaluations, neuropsych, because it's basically paper and pencil. Well, that's the 20th century. In the 21st century, cognitive science involves not only paper and pencil, but cognitive science now involves medical technology in the form of diffusion imaging, PET imaging, functional MRIs, quantitative EEGs, and sometimes even a regular EEG. I can look at a regular EEG and I can say, well, look, let's take a look at brainwave factors, because why do we concern ourselves with brainwave factors? Because there are behavioral correlates to brainwave activity. Children with dyslexia, for an example, have a different biological profile than on their EEGs. For an example, children with dyslexia have a higher theta over beta ratio. That's what we call reverse asymmetry, because you should have higher beta activity than you have theta activity. Now, when we start talking about things like that, then I can tell you, and I could talk to Dr. Hines, like I said, Dr. Hines, your child truly does have dyslexia. Dr. Walks, your son truly does have ADHD. But until I see that evidence, then you probably have someone who's been given the diagnosis based upon teacher observation or parent observation, and they're over-diagnosing these children, they're over-medicating these children, and it will only frustrate you in the longer, because a child with attention deficit disorder will have attention deficit disorder as an adult. A child with dyslexia will have dyslexia as an adult. Now, of course, they have many more options because they are adults, but childhood disorders, children don't grow out of these things. I mean, and that's what I wrote and that's why I wrote Gray Matters, by the way, because I was hell bent on helping people understand that these are not things that children have that they're going to magically grow out of. They have them for life, and until we intervene early, we expect these things to happen.
Okay, Dr. Maxey, I know we are way over time. Was there anything from Dr. Neighbor-Stevens or Dr. Hines in the chat that we needed to deal with?
Well, one thing for sure is, could we put the slide up again showing the names of his books so that people can track?
And Dr. Walker, there are two people on the phone I want to recognize for a comment if they're there. One is Judy, if she's there. Simon, is Judy there? And there's Dr. Carolyn Teague, who's a psychologist in Cincinnati. If you could unmute those two people in the meantime.
Maybe Dr. V, you can put your book titles in the chat as well.
Okay, I will. I'm going to put them
Yeah.
now. Give me a
I-
second.
Can you unmute Dr. Teague, Carolyn?
Okay.
I do see a Carolyn on the
Okay, I think
board.
that's Dr. Carolyn Teague.
Okay, there we go. She's unmuted, Dr. Maxey.
Okay. Dr. Teague, do you have a comment, or I know you had something in the chat?
I do. I haven't heard anyone mention vision dysfunction. And what I would like for everyone to know is that vision dysfunction is a condition that accompanies every other disability, like ADHD, sensory processing disorders. It never gets identified, and it is a life-changing condition that is never identified because insurance won't cover it. And just look that up, Google it, vision dysfunction, and see what it involves. It changes children's lives when they get the therapy that is needed. And children that have originally been diagnosed as ADHD, they find out that they are really not. They have vision dysfunction. They have to use a lot of energy to try to pay attention and traverse and navigate school. So that's all I want to say. Vision dysfunction, look it up. It's very, very important.
Well, thank you. And Simon, is Infanlaya on?
No, I don't see her.
Okay. Anything in the chat, Dr. Neighbor Stevens, you saw, or Dr. Hines, you want to deal with?
I will try to summarize a couple of questions into one, but it was what is the role or the utility you think in some of these evaluations, especially in the imaging, as it relates to like the school prison pipeline and potentially inherited behaviors from folks with violent tendencies or violent proclivities?
Well, the earlier they are identified, as I said before, the earlier they're identified, I always take a look at, developmental trajectory. And I also take a look at neurodevelopmental trajectory because it tells you where the child should be for that child's specific age. I will say that I did a lecture that was discussing the school to prison pipeline. And what these researchers found was that children who have reading problems, Black males who have reading problems, are typically those who will end up in prisons. I'm very concerned about children with reading problems because they tend to be the population at most risk for school dropout or school expulsion, which will lead to other problems as well. And again, as I said before, as the participant just said, mentioned about eye problems, yes. And my thing is, yes, rule all those things out. Ophthalmologist examination, pediatric examination, so forth. These things have to be ruled out fundamentally. And then again, then there's rehab, because once we have identified the problem, then we can appropriately provide effective remediation for these children. And that has been my fight. Let us first empower our communities to let them know that there are alternative treatments. There's 21st century treatments available for children right now. Unfortunately, there's just a tremendous void in knowledge between what they know and what we know that works best for their children.
Dr. V, this has been so great. I've gotten about a number of texts from my controllers that we're over time, but I want to definitely let you know that you're invited back, and we'd like you to head up a series on this. I think the interest level is high, the learning is high. My last question is, I grew up in the era where corporal punishment was part of life of those of us of a certain age, and I'm sure that my father gave me a coup, counter coup injury or two in life. And,
That's not right.
And I had a conversation with my daughter regarding her 9-month-old baby. And she said she's never going to hit him and never going to whip him. And looking at that synaptic disconnection that can happen to rollovers, I wonder what effects some of those things that we got assaulted with when we were kids might have an effect. And if you can't answer that today, I sure want to hear an answer to it later.
No, I'm going to answer right now. Look how you turned out.
Before we close out, Dr. Maxley, one thing I did want to say to Dr. V, these presentations, when I say these, I mean any academic presentation, sometimes they can be very, very, very clinical, if I can use that word. And I really appreciate you sharing your history with your father and the changes in your father and how that impacted your family. I think it makes the presentation much more personal.
Yes.
And we really appreciate you sharing some private information with us. So thank you for that.
You're welcome. Thank you so much. Dr. Maxey, thank you so much again for this.
Thank you.
Humbling.
Dr. Neighbor-Stevens and Dr. Hines, any final?
My final is actually technical final. So we have been having some issues over the last several months with the system that sends the invitation out for the Sunday meeting. It's called MailChimp. And unfortunately, the way it is set up, if you have forwarded the invitation to anybody and that person unsubscribes to it, it knocks everybody out who you forwarded the invitation to. So if you notice that you are not getting the emails the way you used to, you are probably caught up in that. And I'd like to call your attention to, I think it's the third chat from the beginning, when where you will find where you need to re-enroll into our mailing list so that you will receive the invitations in the future.
Okay. And there's certain individuals I sent out a lot of those forms to today, because I know I send them special invitations every Sunday, but I'm trying not to have to do that. So make sure you re-sign up. Dr. Hines?
I'm just, certainly thankful and grateful for such a wonderful presentation. And I came away certainly with the move to the 21st century with the way that you're thinking about these things. This one was certainly personal for me. So I really appreciate it.
Well, again, Dr. V, this has been wonderful, and thank you so much. And
thank you.
I'm definitely super impressed and want to learn more. So I'm going to learn more about the brain. I know about the kidney. Now I need to know about the brain. So thanks, everybody. Have a great rest of your Sunday, and we'll see you. What's our program next week, Dr. Neighbor-Stevens?
Next week, we're going to be talking about climate impact on the community in terms of natural disasters. Our speaker is Dr. Armin Henderson in Miami.
Okay, and then the Sunday after that, we have Dr. Sherrod, who is related to Dr. Jessie Sherrod, and she's going to speak to us on molestation. Okay, and just out of respect, Dr. Wilbur Jordan, you got a short word? Okay.
I don't see Dr. Jordan still on.
Okay. Well, everybody have a great Sunday. And thank you again, Dr. V.
Bye, everyone.
Bye.
Bye.